Hello everyone, my name is Swarnim Adhikari and I am 4th year medical student from Institute of Medicine. So in this video on the series of gynecology lecture, I am discussing on the topic of postmenopausal bleeding. And so this is one of the very important topic for the clinical examination, clinical theory, the bedside viva, and it is one of the frequently asked questions. So it is one of the frequently asked questions. So it is one of the most known topic of the gynecology. So what is postmenopausal bleeding? The bleeding per vagina following established menopause is known as postmenopausal bleeding, and the significance of postmenopausal bleeding is very much high. As many even one third of the case are due to malignancy, and also we have to give importance to the all those cases of normal menstruation which is beyond 55 years. So it is one of the very concerning and significant problem, the postmenopausal bleeding. So there are various different causes of postmenopausal bleeding. Here I have listed the 12 different causes of postmenopausal bleeding. So if we can remember just top 6 of them, then that will be enough. So first of all, talking about senile endometritis. What is senile endometritis? Following menopause, there is the deficiency of estrogen, and the defense of cervico-vaginal canal is lost. So due to there is no periodic shedding of endometrium, due to that the organism of very low virulence ascend up to the infect the atrophic endometrium, and due to that there will be intense infiltration of polymorphonucleoside, that is neutrophil, and also the plasma cell, and due to that the endometrium become ulcerated and it is replaced by granulation tissue, and the purulent discharge that appears escapes out from the uterine cavity, and it result in the vaginal discharge, sometimes offensive, sometimes blood stained. So it is one of the cause of postmenopausal bleeding. And second is endometrial hyperplasia. Endometrial hyperplasia occurs due to their unopposed estrogen stimulation on endometrium. Various risk factor for endometrial hyperplasia are like unopposed estrogen stimulation, delayed menopause greater than 52 years, polycystic ovarian syndrome, nulliparity, tamoxifen therapy, diabetes, obesity, hypertension, insulin resistance, estrogen secreting tumor. So there are various different causes of endometrial hyperplasia, and we will discuss about this topic in some later video. So that was about endometrial hyperplasia. So what is dysfunctional uterine bleeding? The dysfunctional uterine bleeding is a state of abnormal uterine bleeding following an ovulation due to dysfunction of hypothalamo-pituitary ovarian axis due to endocrine origin. So this has an endocrine origin, and it is a state of bleeding where there is no clinically detectable organic, systemic and iatrogenic cause. It is due to the physiological dysfunction and the bleeding occurs. That was about dysfunctional uterine bleeding. So next is genital malignancy. So starting from vulva to above, if we go anatomically, there will be carcinoma of vulva, vagina, cervix, endometrium, fallopian tube. In all this there will be postmenopausal bleeding. And also sarcoma of uterus. Endometrium is the cancer of the mucosa, whereas sarcoma is a cancer of endometrium is cancer of epithelium, whereas sarcoma is malignancy of the smooth muscle part. So there it also postmenopausal bleeding occurs in this case. And also in the granulosa cell tumor of ovary, there will be postmenopausal bleeding in this genital malignancy. Also 1/3 of the cases are due to genital malignancy. This is very important cause. In the postmenopausal bleeding, it is mandatory to rule out these causes. And also decubitus also in the in prolapse, and also retained and forgotten foreign body like pessary and IUCD. Some female may put the pessary IUCD and they may forget, and that may cause postmenopausal bleeding. And also in other causes, there are some other causes like senile vaginitis, cervical erosion and polyps, uterine polyps, cervical polyps, uterine polyps, like urethral caruncle polyp, Now, there are three types of polyp: cervical polyp, uterine polyp, and urethral polyp. In these three polyps, there will be postmenopausal bleeding, and there is prolapse mucus or carcinoma. There in tubercular endometritis also there is postmenopausal bleeding. Tuberculosis is very important organism in some developing countries like ours, so this might be important cause. And in 25% case, it is unknown. Unknown. And so that was about the causes of postmenopausal bleeding. So if you can remember, what were these top 6: senile endometriosis, endometrial hyperplasia, dysfunctional uterine bleeding, the malignancies, decubitus ulcer, and retained foreign body. So these are the causes. And the polyps, 3 types of polyp, and in tubercular endometritis, and one is unknown, so let's forget that. So how can we diagnose endometrial postmenopausal bleeding? First one is detailed history. So it is important in initial step. It is very important to establish the fact that it is vaginal bleeding, but not a bleeding per rectum and or hematuria. We have to rule out that. We have to take history very sincerely and rule out that this is vaginal bleeding, but not a bleeding per rectum or hematuria. So in history, we have to ask about our age of menopause. What was our age? This is very important. As we just discussed, in endometrial hyperplasia, there is delayed menopause. So age of menopause is very important. And the menstrual pattern prior to menopause. What was her pattern of menstruation before menopause? Amount of bleeding, number of episodes, what was the amount of bleeding, about the menstrual history. We have to take it in very sincere manner. And also we have to ask about the sensation of something coming out of introitus to rule out prolapse. And we have to ask about the urinary problem like dysuria or frequency of urination. And we have to ask about the history about intake of estrogen. If there is even if history of intake is present, the full investigation should be carried out to exclude malignancy. And also we have to ask about family history of endometrial and ovarian carcinoma in first degree relatives. So that was all about history. Majority, as we all know, history gives very much important clue to diagnosis, and this should be not be missed at any cost. So that was about history. And in clinical examination, blood pressure, BMI should be determined, as obesity, diabetes, and hypertension are often related to endometrial carcinoma. We have to check the lymph node. The enlarged groin or supraclavicular lymph node may be palpated. It is in the metastasis. There will be lymphadenopathy. The metastatic nodules in the anterior vaginal wall can be present. The breast should be palpated because of gynecological symptom may be related to the breast cancer. In breast cancer, there will be maybe gynecological symptom. So we have to rule out we have to check the breast. And we asked about the per abdomen examination. A lump in lower abdomen may be due to pyometra or uterine sarcoma or adnexal marks. We have to check about the perineum. Then if uterus is outside the introitus, or decubitus ulcer may be detected. Decubitus ulcer if uterus is outside the vagina. Also, careful inspection of vulva may be reveal a growth, and we can find anything that may be suspicious. And if say there is any suspicious growth is present, then we have to take biopsy. And after that, we have to palpate. We have to separate the labia for better inspection of urethral meatus to find out if there is any caruncle, polyp, or mucosal prolapse. After that, we have to do speculum examination to note any condition of cervix and vault of vagina. And if there is any visible cervical growth, biopsy should be taken. If cervix apparently look normal, then we have to do cervical and endocervical smear to exclude dysplasia or carcinoma in situ. So where the speculum examination is very important and very routine practice in OPD. So that was about the speculum examination. And also the bimanual examination is very important. And the uterus, we can see that uterus may be either normal, atrophic, or enlarged due to the pyometra or sarcoma. The adnexal mass may be palpable. So that was all about history and clinical examination. These are the baseline thing that we can do. And about the then we have the special examination. We have the ultrasonography. Transvaginal ultrasonography is more accurate because of its proximity to the larger target tissue. It is closer to the target tissue like endometrium. Endometrial thickness less than 5 mm indicate atrophy. On the other hand, the thick polypoid endometrium 9 to 10 mm irregular texture fluid within the uterus require further evaluation to exclude any malignancy. The 3D sonography with Doppler studies are more informative. And also we can do saline infusion sonography, SIS. This is more accurate compared to sonography alone, and the biopsy should be taken after that. And we can do hysteroscopical evaluation and directed biopsy. We can do endometrial biopsy alone. Can we do using a pipial cannula or Sorman's curette as an outpatient basis. The endometrial biopsy for diagnosis of endometrial carcinoma under guidance of sonohysterography or hysteroscopy has got the similar diagnostic accuracy. The thickness of endometrium less than 4 mm using transvaginal sonography is suggestive of atrophic endometrium. Biopsy is indicated when endometrium is thick. So that was about endometrial biopsy. So, and next thing is fractional curetage. Fractional curetage is done if cervical cytology becomes negative. Okay. If cervical cytology becomes negative, then we have to do fractional curetage. And a laparoscopy, we have to do laparoscopy in suspected case of ovarian or adnexal marks. And in CT and MRI, where this can be done in selected cases of postmenopausal bleeding where malignancy is suspected in carcinoma cervix and endometrium. So this was all about the diagnosis, detailed history, examination, and investigation. And about the treatment, so if after the diagnosis is complete, we have to treat the underlying cause. If cause is diagnosis, if the treatment is direct to it. If we cannot detect any cause after the extensive investigation, then we have to do the careful observation. Careful observation is mandatory, and we have to do conservative treatment. And in cases of recurrence or continued bleeding, whatever may be the amount, it is better to proceed for laparotomy to perform hysterectomy with bilateral salpingo oophorectomy. So we have to do the surgery and we have to remove the uterus along with fallopian tube and ovary. So that was all about. So this is final approach, and that was all about postmenopausal bleeding. So if you find this video useful, then you may take a screenshot of this note and copy it. This is the reference for this note is DC Datta's textbook of gynecology 9th edition. So that was all about postmenopausal bleeding, and next time we will come up with some other important topic of gynecology and obstetrics. Thank you.